Welcome to Case-Based Educational Curriculum. This case is one of a young woman who presents with altered mental status. This is a 20-year-old female who's brought in by her family with the complaint of confusion that started yesterday and today minimally responsive. They also note that she has very fast breathing. The family brings her to a bed and lays her down, and the nurse comes to get you. As you walk up to the bed, this is what you see. The first thing that should be going through your head is this an emergency or not an emergency? And I hope you answered yes, that this is an emergency. This patient has altered mental status and an abnormal breathing pattern, both of which are very concerning. You get a set of vital signs and you find that her heart rate is 128, her respiratory rate is 28, her blood pressure is 130/56, her temperature is 37.5 degrees Celsius, and her oxygen saturation's 98% on room air. What else would you like to check right now? Glucose. I would recommend getting a glucose upon arrival of any patient presenting with altered mental status. Her glucose is not low, but rather very high at 542. What do you want to do next? Stabilize the patient. Any critically ill patient, as this one is, should be stabilized as soon as they arrive by assessing their airway, breathing, and circulation. As you assess her airway, again you note that she is minimally responsive. Her airway is open and she's moving air well, and there appears to be no obstruction. Patients with altered mental status often do not protect their airway well and oftentimes need assistance with a nasopharyngeal airway or an oropharyngeal airway. It is also recommended to have airway equipment nearby and available for any patient with significant altered mental status in the event that they decline and need airway protection and assistance. When you assess her breathing, you notice that she's taking very deep breaths and her respiratory rate is elevated. Her oxygen saturations are 98% on room air. This is adequate. However, this patient is critically ill, and it would be recommended to put oxygen on any critically ill patient, even if their room air saturation is adequate. When you assess her circulation, you note again that she is very tachycardic. Her blood pressure is adequate at this time, but should be watched closely. Her peripheral pulses are intact. But you also note that her mucous membranes are very dry and she seems dehydrated on exam. Now that you have done an initial assessment and you feel that her airway, breathing, and circulation are for the time being stable, you go on to do a more thorough physical exam. On her head exam, you don't notice any trauma and her head is normal cephalic. When you examine her face and her mouth, you notice that her mucous membranes are very dry, and you also notice a fruity odor on her breath. Her neck has a midline trachea, no JVD, and a supple neck. Her lungs reveal clear auscultation bilaterally, but she does have a rapid breathing rate. Her cardiac exam reveals tachycardia, but regular rhythm. Her abdomen is soft, appears to be non-tender and non-distended. Her extremities show no edema, bruising, or deformity. Her neurologic exam, she's not responsive to voice, but she does open her eyes a little bit and moves her arms to painful stimuli. Her skin reveals no rashes. Now that you've done an initial assessment and a physical exam, her family is at bedside and you try to obtain more information about the patient and what is going on. They're able to provide the information that she is a diabetic. She has been diagnosed with diabetes in the past and used to take insulin for it. They have not been able to get her insulin for the past 3 months. She takes no other medications. She doesn't have any other medical problems that they know of, and she has no known allergies. To note, it is very important to obtain history from family members or medical personnel if she comes on an ambulance, um, as patients with altered mental status often cannot provide information for themselves. And this information is oftentimes very important in finding the underlying cause of the patient's altered mental status or their condition. What should we do next? In any critically ill patient, you should place them on oxygen, establish IV access and start fluids, and place them on a monitor for close surveillance. We already did this while we were assessing her airway, breathing, and circulation. So what is our differential diagnosis? Well, in a patient with a history of type 1 diabetes who has been off of her medication, has very high blood glucose, appears very dehydrated, with altered mental status, and that abnormal breathing pattern, it is very, very likely that she has diabetic ketoacidosis. However, we always want to keep a broad differential diagnosis and consider other things. So other things that may present in this way could be sepsis, some type of intoxication or poisoning, meningitis, pneumonia with the rapid breathing, or even renal failure or liver failure for that matter. So as you can see, there are some similar findings on exam and vital signs shared between these different diagnoses, particularly things that are infectious, so sepsis, meningitis, pneumonia. These all may present with fever, altered mental status, rapid respiratory rate, and maybe signs of dehydration and shock. DKA often presents in this way as well. Some things that are unique to diabetic ketoacidosis are sometimes you can notice a fruity odor on their breath from the ketones in their blood. Also, while other infectious causes may show a mild hyperglycemia, DKA usually has a much more profound hyperglycemia greater than 250. Particularly for this diagnosis, it's important to get a good history because oftentimes that information will be imperative in making the diagnosis, including maybe the history of diabetes or history of symptoms of diabetes if it's not already diagnosed. And also if they're already taking diabetic medications but haven't been able to take them, as this young woman hasn't been able to take her insulin. So some physical findings that are very suggestive of DKA are signs of dehydration, such as dry mucosa, sunken eyes, prolonged capillary refill, tachycardia, and signs of shock. This is a young man who also presents with diabetic ketoacidosis, and you can see that his mucous membranes are very dry. Another common finding in diabetic ketoacidosis is this abnormal respiratory pattern called Kussmaul respirations. It is deep and rapid breathing, and both our young woman in the case as well as this young man are demonstrating this breathing pattern. Also, you can, as I said before, sometimes smell a fruity odor on their breath, and that is of the odor of ketones or ketosis. What labs would we like to order? Well, initially, we will want to get a glucose, which we already have, and this glucose should be checked every hour. A venous blood gas, electrolytes, including potassium, sodium, as well as calcium, magnesium, and phosphorus, if possible, BUN and creatinine to assess renal function, a CBC, assess ketones, which can be assessed in the urine or the blood, a urinalysis, and likely will send cultures. Other labs may be determined case-by-case scenario depending on the presentation of the patient, including other lab tests like lipase or amylase and certain imaging modalities. As far as imaging does go, usually you would want to get a chest x-ray on any patient that presents with an abnormal respiratory pattern. Also, infectious causes, infections can be a cause of a diabetic patient going into diabetic ketoacidosis, so you want to rule out a pneumonia. A CT scan of the head is often obtained in patients that present with altered mental status of unclear etiology. It is not absolutely necessary in a patient with known diabetes who is clearly presenting with DKA with no other history of trauma and no suspicion of significant cerebral edema. So how do we diagnose DKA? As I said before, this young woman with type 1 diabetes who hasn't had her insulin presents with significantly elevated glucose, abnormal respiratory pattern, decreased level of consciousness, and a significantly elevated glucose is um, certainly certainly has DKA, but the actual criteria to diagnose DKA include these four lab tests: a glucose greater than 250, an arterial pH less than 7.3, a serum bicarbonate of less than 18, and the presence of ketones. Also, you usually see an anion gap that is elevated. Let's briefly look at the pathophysiology and review this pathophysiology of DKA. Essentially, you have an insufficient or absence of insulin in type 1 diabetes. This is because the pancreas is not producing insulin, which affects the cells of the body, which can't use the glucose. Therefore, they break down cells to produce amino acids, glycerol, and fatty acids. In the liver, these products are used to produce glucose and ketones, and these processes, glycogenolysis, gluconeogenesis, and ketogenesis, release large amounts of ketones and glucose into the blood. Therefore, in the blood, we have ketosis, so we have a large amount of ketones in the blood. We have a large amount of glucose in the blood causing hyperglycemia. The ketosis causes an acidosis, and the body diureses with this elevation in serum osmolality and causes a severe dehydration and volume deficit. The average volume or water deficit in a patient with DKA is 6 liters, so that's very significant. So the treatment for DKA is to reverse these processes. So fluid is the primary and first treatment for DKA because the body, as we've already seen, is massively dehydrated. It also helps to lower and regulate the blood glucose levels. Insulin not only is used to lower blood glucose, but its actual primary purpose is to correct the ketoacidosis. We need to replace potassium as the body has a total body depletion. And also important in the treatment is to address the underlying cause of DKA, which oftentimes can be an infectious process or some other stress to the body. So as far as IV fluids, initially you'll assess the hydration status with vital signs, physical exam, and urine output. For our patient, she appears very dry on exam. Her vital signs support this with tachycardia, and she has decreased urine output. You start with normal saline at 1 liter per hour. And again, remember these patients are often 6 liters, have a 6 liter deficit. After each liter bolus, you need to do serial exams to assess hydration status. And you continue normal saline fluids until the glucose reaches 200. At this time, you change to D5 half normal saline at 150 to 250 mLs per hour. You add the dextrose at this time so that the patient does not develop hypoglycemia. Here we start IV fluids in our patient. Insulin is started after fluids are started. Insulin is started as a continuous infusion, usually 0.1 units per kilogram per hour, up to 0.14 units per kilogram per hour. While they're on this continuous infusion, you need to check the glucose every hour. If the serum glucose does not fall by 50 to 70 milligrams per deciliter in the first hour, you can double the IV infusion. You don't want to drop the glucose as fast as you can. In fact, the ideal rate would be 50 to 70 milligrams per deciliter per hour. Again, you're checking the glucose every hour, and when the glucose reaches 200, you don't stop the insulin, as the insulin is used to treat the ketoacidosis, but you reduce the infusion to 0.02 to 0.05 units per kilogram per hour until the DKA is resolved. And you continue to check the glucose every hour because you want to keep the glucose between 150 and 200 milligrams per deciliter until the DKA is resolved. Here we start an insulin pump for our patient, a continuous infusion at the rate described. So the total body potassium is low in the patient with DKA, but because of transcellular shift, sometimes it can look elevated when in actuality there is a total body depletion. Before you replace potassium, you have to make sure they have adequate renal function with at least 50 mLs per hour of urine output. Once that is established, if the serum potassium is less than 3.3, you actually will hold the insulin and give 20 to 30 milliequivalents per hour until the potassium is greater than 3.3. This is because insulin will lower the potassium even further. If the potassium is greater than 5.3, do not give potassium, but continue to check it every 2 hours because it will drop with the insulin treatment. And once it is below 5.3, you will give potassium. So if the potassium is between 3.3, and 5.3, then you give 20 to 30 milliequivalents of potassium in each liter of IV fluid given to keep the potassium between 4 and 5 milliequivalents per liter. And you will be checking the potassium every 2 hours. So ongoing monitoring, we recommend you check the glucose by glucometer every hour. Every 2 hours, you check a blood gas to assess the pH of the blood. And at that time, you'll also check a serum glucose from the lab to assure accuracy. Every 4 hours, you need to check electrolytes, particularly the potassium. If you are unable to do these labs at your hospital, you should strongly consider transferring the patient to a higher level of care. If for economic or social reasons you cannot transfer the patient, then at least very minimum you have to check the glucose every hour to assure that the patient's glucose is dropping at an appropriate rate and that they are not becoming hypoglycemic. You'll continue to do this until the patient is clinically improved. And when the glucose reaches 200, you'll add dextrose to the fluids, continue the insulin until clinically it appears that the diabetic ketoacidosis has resolved. As far as disposition of this patient, our patient is very ill and she needs ICU level of care. All patients with DKA, particularly those with altered mental status, need to be in an ICU and should be transferred if necessary. When have we reached our goals of treatment? Well, you can stop the insulin infusion and change to subcutaneous insulin scheduling when all of the following have been reached. The serum glucose is below 200, the serum anion gap is less than 12, or less than the upper limit of normal for your lab. The serum bicarbonate is greater than 18, and the venous pH is greater than 7.30. So now we can answer some commonly asked questions about DKA. First of all, do I want to lower the glucose as quickly as possible? No. This can lead to cerebral edema. Ideally, you want to lower the glucose about 50 to 70 milligrams per deciliter per hour, as we stated before. If we're concerned about cerebral edema, shouldn't we restrict fluids? No, these patients are very dehydrated, as I said, an average of 6 liters of water deficit, and they need IV fluids. Serial neurologic exams should be done every hour to make sure that this rare complication does not occur. Should I treat hyperkalemia? No. Patients with diabetic ketoacidosis have a total body potassium depletion, and apparent hyperkalemia is due to a transcellular shift. This potassium will lower with insulin treatment, but potassium should be checked every 2 hours. Should I treat acidosis with bicarbonate? No. Studies show that this can be harmful and should be reserved for patients only patients with severe acidosis with a pH less than 6.9. Do I stop giving insulin once the glucose is normal? No. Insulin should be continued until the ketoacidosis has resolved. D5 should be added to fluids once the blood glucose is 200 to avoid hypoglycemia. Should I give a bolus of IV insulin before starting the IV infusion? It's not necessary and is now actually recommended that you do not. Continuous infusion of insulin between 0.1 and 0.14 units per kilogram per hour is just as effective in treating DKA as a bolus plus infusion, with less risk of large osmolar changes, which puts the patient at risk for cerebral edema. So in summary, diabetic ketoacidosis generally occurs in patients with type 1 diabetes. It is characterized by a triad of hyperglycemia, ketonemia, and acidemia. It is important to find the underlying cause, which is often infection or medication noncompliance. Common symptoms include polyuria, polydipsia, weight loss, tachycardia, signs of dehydration, and even shock. Successful treatment includes correction of volume depletion with IV fluids, reversal of the ketoacidosis with fluids and insulin, and correction of electrolyte imbalances. These patients are critically ill and require intensive care level of management. Thank you for joining us on this case-based educational curriculum on diabetic ketoacidosis.